All right, we are live. Hello, my friends. It's Jill Osborne from the Interstitial Cystitis Network. It is Sunday, December 28th, our last meeting of 2025. We will see how long I survive because I still have the SuperFlu. And yes, my friends, that is what they are calling it now. I am starting week 4. So anyway, let me introduce myself. My name is Jill Osborne. I'm the president and founder of the Interstitial Cystitis Network. I'm the longest serving IC support group leader in the world. I will be starting my 33rd third and a half year. And I work as an IC researcher. I do wellness coaching. I write a lot of books. I write websites. You name it, I do it. My goal here is to find those patients who are suffering in silence at home alone, for those who have been told that they have an incurable bladder disease, or worse, they've been told that this is all in their head. We are here for you. Now, just fair warning here, it is still the holiday and people are traveling today. And so I don't know what's going to happen today. Sometimes our meetings last five hours, sometimes they last 90 minutes. It is what it is. I'm just very, very flexible. I have other things that we can do. Also, I'm going to say right now, last week, YouTube completely malfunctioned and I couldn't read anything that you were writing to me. The chat literally was empty. And so for those of you who are watching on YouTube, if you're watching live, please know that if there's something that a question for me, if you could test the chat right now, if you could, because I see a couple of people in there right now, if you could write in the chat, let's even see if it's working. If it's not, you can reach out to me by email and I will read your email online. Out. I won't use your name, of course, but if there's a question that you have for me, I am here. Hello, Facebook. So we are live streaming on YouTube and Facebook right now. There we go. And for those of you on Facebook, I need you guys to check your chat too. Somebody could write in the chat window and let's see if that's working. That's fine. I always think now that when technology isn't working right for one reason or another, or I'm working on something and the software freezes or the internet freezes, I always think that that's my angel saying there's other important things for you to do right now rather than this. So I don't let technology upset me so much anymore. So how many of you got the flu? I don't know about you, but out here in California, it is chaotic. People are dropping like flies. This new H3N2 subclade K SuperFlu, they're now calling it a SuperFlu because it is so severe, hit my family at Thanksgiving. Like literally somebody came to Thanksgiving and they brought it with us and everybody in my family dropped. I got it the worst, I think. Tina, thank you so much, Tina. It is working. I see that. For those of you on YouTube, yes, I can see you. Yes. Excellent. So now we have communication with YouTube. I'm so glad. So bear with me if I start coughing. That's where I am now. I'm just in I'm in the constant coughing mode, nausea mode. But I'm nauseous because I'm on blood thinners. That's a whole nother story. Okay, so let's talk about this flu just for a moment. This is a highly contagious influenza A mutation. It is not covered in the flu shot. The mutation happened in Asia in July after the flu shot was developed. As a result, you are not protected by the flu shot. You might have a slightly easier response to it, but people who have had the flu shot have gotten very, very severe flu from this too. We have all been notified that we are to expect a very severe flu season, if not a deadly flu season, because of this influenza mutation. It presents first with a sore throat so bad you feel like razor blades are cutting cutting your throat. In fact, what was funny is I was talking to somebody in Florida and they asked me how my holiday was. And I said, well, I've been sick. And she goes, oh my God, you don't have the razor blade throat, do you? People are calling it the razor blade throat. Literally, the throat is so severe, you feel like you're being cut with a razor blade. It's hard to swallow. You're thinking strep, but if you go to urgent care, your strep test is going to be negative. The other thing that's very frustrating about this very, very severe sore throat is that if you try a cough drop, there's a very good chance it's going to hurt. I was talking with another patient who had exactly the same experience I'd had, which is my normal Ricola cough drops actually hurt like a beast. The only thing that helped the sore throat for me was Chloraseptic. And Chloraseptic lozenges. That's the stuff that really numbs your throat and kind of gets you through that. So for anybody out there, if you got family members who have the sore throat, get them some Chloraseptic. That is definitely the best. Be prepared for the fact that if you give them just a cough drop out of your old cabinet or cupboard, it might hurt them. Again, it hurt me, and it's hurt a couple of other people that I've talked with too. Then the sore throat might last 2 or 3 days. Mine started Saturday morning after Thanksgiving. By Monday, I was at urgent care. Strep test was negative. They gave me antibiotics anyway. Yada. Okay. So then it migrates into really, really bad congestion. It will start with the sinuses. And we're talking green, thick mucus here, not clear, easy mucus. We're talking chunks of green nastiness. And then it transitions very quickly into a deep, wet cough. And this virus is known for causing pneumonia. I ended up with pneumonia in my left lung. You know, but here's the thing that I think is really important to understand. One of the things that happened to me is I went into AFib, atrial fibrillation. Like literally a week after it started, I was watching K-pop Demon Hunner at 8 o'clock on Friday night, and I felt a switch in my heart go on, and my heart went. I mean, this wasn't just tachycardia, this was atrial fibrillation. And this has only happened one other time for me, and that was after COVID. And it turns out that viruses can attack your heart. COVID is known for attacking the heart. They call it COVID tachycardia. So I developed tachycardia for many months after I had my last COVID infection. Then I went into AFib when I had my COVID vaccine, and now I went into AFib again. I found a journal article yesterday that went through all the viral infections from, just from influenza to herpes to respiratory viruses, et cetera. And specifically what they do to the heart, they actually physically damage the heart. They physically damage the heart. They can actually turn off one of the nodes in your heart and kill you. I mean, in a very, very severe, deadly infection. So viral infections are nothing to laugh at. This is a really, really bad, dangerous flu going around. Listen, I'm 4 weeks in. I am still not back to normal. I still feel ill. I don't feel terrible like I did. I don't feel like I'm dying like I did 2 weeks ago. But now our graphic designer, she came down with it several days ago. Another friend and her husband started developing symptoms last Sunday. It is pandemonium here. Our ERs and our urgent cares are filled. I have another IC patient who called who Ann says it's going around here in New Jersey too. Man, it is sky high in New York. And my worry is that with all the travel that's happening right now, it's just going to go into more and more homes. I have another IC patient who's a very, very dear friend of mine who is going to go to a retreat on New Year's with a group of people, and she decided not to go because that's how bad this is. So Please, please, please protect yourself. I don't want what happened to me to happen to you. If you're going to go into any crowds, wear a mask. And I wouldn't be going to the movies. I just, right now, man, this is all about lockdown. Protect yourself. It is rough. Now, if you do happen to get a cold or a flu, we did a very large research study, a survey of thousands of patients a few years ago to ask what their best IC-friendly strategies were for cold and flus. And so I want to take a moment and go through those so that you will have those on hand if this does happen to strike you and your family. So hold on. Let me grab those real quick. Okay. Here we go. Okay, so for sore throat, for you dealing with a sore throat, again, for this one in particular, Chloraseptic, first choice by far, because it numbs the throat. I see patients, however, they do best with honey lozenges. So Pine Brothers or Zarbee's honey lozenges are perfect favorite, perfectly bladder friendly, not getting irritated at all. Our second best is Ricola lozenges. Our third best is Ludens. Okay. They mentioned some other ones, but really it's just a plain simple honey lozenge was good. I will tell you, I was doing a lot of hot water with honey my first 10 days. Okay. What are our favorite over-the-counter cough products? Number one, Halls. Number two, Ricolas. I'm doing the, they look orange, but they're not orange. I should go get them. I'm doing Ricola drops right now. They're doing okay. You can do Robitussin honey, cough and congestion drops. You could do Robitussin max strength, or you can do Ludens, but the Hall cough drops appear to be the best. You know, it's almost like the nerves in your throat become really, really inflamed and hypersensitive. And so I'm going to put the Chloraseptic drops as being very, very helpful, even though they're for sore throat, to try to calm this persistent cough down. Other mentions for coughing were Pine Brothers honey drops, Boiron Cheetle honey congestion, using a humidifier, using Buckley cough products, Mucinex, and of course, my all-time favorite thing is Vicks VapoRub. Vicks VapoRub everywhere, like everywhere. I don't care if anybody can smell it on my body. If I am congested, I'm going to have Vicks VapoRub from here to here. And maybe even under my nose. What are our favorite decongestion products that are bladder friendly? Number one, Mucinex. Number two, Vicks VapoRub. And number three, Sudafed. Please know, however, that Sudafed is associated with a lot of potential side effects, including racing heart and bladder wall flares. Have any cold and flu products given you a severe flare? So according to IC patients, their biggest flare triggers are products that contain citrus, pseudoephedrine, red dyes, alcohol, and vitamin C. One patient had a particularly harrowing experience. She wrote, I took Tamiflu for the flu last year and wound up with hemorrhagic cystitis. Don't know if there was a clear-cut connection, but I would think twice about doing it again. My flu still lasted 2 weeks. The cystitis may well have been caused by my depleted immune system, but who knows? I am now a believer in preventative flu shots. Yeah, if only the flu shot actually covered this specific flu. Tamiflu is one of several antivirals that might be available. You have to understand, though, that they are all associated with potential side effects. The most common side effects of Tamiflu, and it was never offered to me, by the way, was confusion, tremors, shaking, hallucinations, nausea, vomiting, headache, and pain. But it can also reduce the length of an infection and potentially save some lives. So you have to talk with your doctor about the pros and cons of that. Of course, many patients flared with lemon products or cranberry products. Another patient said she avoided anything with Benadryl, any Sudafed, anything with red dyes, any lemon or cherry products, anything with vitamin C, things like Airborne, things like that, and any cough medicine with alcohol. So for me, I'm going to tell you right now, my personal go-tos are Chloraseptic. Oh, come on. Sucrets. My second favorite cough drop is Sucrets. This is pretty good. I have to say, this is pretty good. The Chloraseptic is better, but this is pretty good, especially for day-to-day use. Lots of gargling with salt water, nasal washes, Ricolas, and then also there's a new brand called Open Nature lozenges that it's particularly good, and it's not too sweet, so I really like those two. And of course, having a humidifier on all of the time. So, you know, every year is an adventure. Every flu season is an adventure. And the funny thing here is that, like, I did Christmas alone because I've been sick. My whole family was sick, but again, I had the luck or bad luck of it causing AFib, and I do not like being into AFib. I do not like how that stresses your heart out, and I do not like taking an ambulance ride to the ER as I had to do 3 weeks ago because my heart was so crazy. So I did Christmas alone, and it's okay. Sometimes you have to put yourself first. Lisa writes, thank you for everything that you do to support IC patients, Jill. Sending hugs from Kansas. Thank you for the 247 stars. Really, really appreciate that. And guys, if you have found these meetings helpful, please consider becoming a member of the IC Network or coming over and buying something in the IC Network shop, because honestly, that's what pays the bills to keep me doing this. And, it was a rough year last year. It's been a rough couple of years. Really has. Now, that said, I just sent out a newsletter where we are doing a 15% off sale of everything in the IC Network shop, including all supplements. That's good through the end of New Year's. And so if you want to stock up for 2026, it's really rare because the manufacturers normally don't allow us to do sales like this, but we're doing a sale, 15% off. The promo code is Happy New Year, all lowercase, no spaces. If you want to stock up on your bladder builder, your bladder rest, or your lactoferrin, or your Cysto Protect, you can go ahead and use that code. One last thing, Cysto Protect has been on a national shortage for a couple of months now. I was just told 2 days ago that they expect to have it on Monday, and they will ship it to us on Monday. And so we have put Cysto Protect available for advance order in our shops, and you can use our sale code to buy your Cysto Protect too. All right. So, that is a quick and dirty update on what's happening in the last couple of days. Anne says, Jill, can you have IC with no pain? Yes, absolutely. Remember, number one, there are degrees to severity. Some patients will just have frequency, urgency. Others will have frequency and urgency and pain. And some patients will have chronic symptoms. Other patients will have mild and or episodic symptoms. And it really depends upon your phenotype. So if we think about that phenotype for a moment, patients with Hunner's lesions are going to have more pain because they have visible wounds in their bladder that urine is getting into and provoking pain and discomfort. If you are an estrogen atrophy patient, so your bladder wall-driven estrogen atrophy, then what we're going to see is certainly more frequency urgency, but the pain is probably not going to be as severe unless you provoke your bladder wall. Our pelvic floor patients are certainly going to have some frequency urgency. Their pain, if they have pain, is going to be a little different. So bladder wall pain is very sharp and shrill. It's like a razor blade cutting your bladder. And it's very, very dependent upon urine in your bladder, because if you have a wound on your bladder wall, and as your bladder fills with urine, eventually that urine is going to get to the wound, go inside of the wound, and cause pain. All right. So that's going to be very different from a pelvic floor patient, because a pelvic floor patient, their pain, rather than being sharp and shrill like a razor blade, their pain is duller, it's achier, it has a burning quality to it. You might feel a pulling sensation or a pushing sensation. And the best way to look at and to determine the health of your pelvic floor literally is just by how you pee. I mean, can you pee like a horse? Are you good? You can just pee like a horse? Or are you stopping and starting? Does it take time to start urination? If you have to hesitate 5, 10, 15, 20 seconds before you relax enough to release urine, then that's a sign that we're dealing with muscles. Our pudendal neuralgia patients are patients who have pain when they sit that gets better when they stand, or they have sciatica. Their pain's going to be nerve pain, and nerve pain is definitely more intense. Nerve pain feels like pins and needles, areas of numbness, or like you're being shocked by something, an electrical shocking pain. And then last but not least, we've got our widespread pain group. We've got patients who have bladder pain, pelvic pain, fibromyalgia, burning, TMJ, migraines, etc. So getting back to Anne's question, well, can you have quote unquote IC with frequency urgency? Of course you can. But IC doesn't mean anything. It's the phenotype that really matters. So now we have to really understand your phenotype to figure out why you have the frequency urgency. Judy says, does your vagus nerve affect your bladder? I do believe that it does, because I do believe that is triggered during the fight or flight response. So when let's say, I want to get this straight. Urination, lacrimation, defecation, and something else. What is it? I don't remember. Urination, declamation. Okay, urination, defecation, lacrimation. I think it's salivation. That when certain nerves get triggered and you go massively into a stress response, and your body is preparing to fight or flee, in many cases, you will spontaneously pee. Your body's saying, get it out now so I can run for my life, because that saber-tooth tiger is going to come after me. And the same is true with defecation, that sometimes when you're under periods of very, very intense stress, your bowels just go. Again, that's part of your whole body preparing and responding to stress. But Judy, I mean, I'd have to, that's all I can say off the top of my head. I haven't really studied or read about that much in the last decade, to be quite honest, though. Hopefully I got that right. I can remember, I was an RA in the dorms at UC Santa Barbara when I was getting my pharmacology degree, and this was back in the early 1980s, because yes, I'm that old. Yes, I'm that old. And I remember very, very distinctly that there were a group of students who had done psychedelic mushrooms on Halloween. And one of them went into a coma. And she was tremoring and salivating and all these crazy things happening. And they came running down. I was down in the office on Halloween night. You got to come up. Your hall president's really sick. And I run into her room, and they're basically monitoring everything and making sure she's breathing. And of course, we call 911. And I can remember that after the ambulance came and took her, I took everybody into the rec room, and I did a lecture on the signs of overdose. And they were, it's like, this is what you look for. Dang, 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 dang. And the only reason I could do that is we just talked about that in my pharmacology classes. So, the crazy lives of college students. Would I want to do it again and live in the dorms again? No. No, 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 no. Nope. Not at all. MW says, so sorry, Jill. Just wanted to let you know I had my brain surgery on December 10th for my large aneurysm. I have 6 coils and 2 stents. It's been a rough recovery, still very dizzy, head pain on and off. Oh my God, honey. Oh, it's over. It's over. And they've treated it. I'm so glad that surgery is behind you, but recovery is rough, and especially recovery from brain surgery. It's very, very rough. So I want you to feel the love and the support from the entire ICs community coming to you right now to help you through this very, very challenging recovery. But congratulations, you did it. Yay, 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 yay. I'm so glad it's over. I'm so glad it's over. Now, I want to show you. So, I have been very, 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 very busy. Although I will say, you know what? I got to be really honest about Christmas. Honestly, on Christmas Eve, I bawled my eyes out. I was so sad that I couldn't be with family. I really was. But I knew implicitly I was making the right decision, because I was not going to walk into a big family gathering with what I'm dealing with. And then when Christmas Day happened, it was like, whew, okay, I can get through Christmas Day. I ended up cleaning most of Christmas Day and just doing stuff. And then finally, yesterday, it's like the first day without the stress of Christmas where I felt like I could truly rest. I actually, for the first time in like 2 years, read a book from cover to cover. The new Webb Griffin book, the new presidential agent book. So good. I painted and I read a book. Oh, it was just, and I feel like that's my goal for the rest of the week, is just to try to heal now. And I think that's what we all have to do after the stress of the holidays, is just get outside, take some walks, just calm down. Now, what I have been doing is I have been writing. I got a lot of writing projects. So, of course, our flare guide has been out now for about a month. Lots of people are getting it, and I haven't had any complaints about it yet. 80 pages on how to handle bladder wall flares, pelvic floor flares, pudendal neuralgia flares, stress flares, menstrual flares, urethral flares, vulvodynia flares, rectal flares, and sex flares. So if you find yourself struggling with flares, you can get this book as a PDF. It's $9.95. Lori said, great ebook. I love getting along. Oh, she read a book too. Excellent. I'm so glad. Okay, so $9.95 is a PDF file, and it's $16.95 in print, and you can get it in the IC Network shop. And then the new one is our new diet guide. And I just have to do the final round of edits, which I did not do on Christmas Eve and Christmas Day because I just didn't want to sit at the computer. So I will be doing that tomorrow. Then it will go to the printer, and then we will have our new diet guide. Very near the same pricing, $9.95 for the PDF file. And it might be, because it's 10 pages more and printing is very expensive, so it'll probably be $17.95, something like that. I'll have to look at the printing there. And then we have more and more. I've got a whole stack of things over on the floor here. I've got our new IC 101 medical journal where you can track your treatments. And then we are working on our new ketamine cystitis book and our new chemo cystitis book. So lots and lots of, that's just what I want to do. I just really feel the need to write right now. So I'm going to be writing a lot. and hopefully creating a lot more videos. Sue says, hope you had a wonderful Christmas and that you're feeling well. We had a very special Christmas present this year. 9 pounds, 13 ounces, a baby granddaughter. Well, congratulations, Sue. Congratulations. Isn't that wonderful? We need these moments of pure and utter joy in these times that we are living in right now. Okay, wait. And hold on. One other thing. Now, listen, because of the federal shutdown, the National Library of Medicine shut down, and we just didn't have any updates on the new IC research. However, hold on one sec. Something new crossed my desk a couple days ago that I thought we should talk about. Let me see if I can find it. Okay, here, hold on a sec. Successful treatment of bladder pain syndrome with Montelukast or okay, oh my God, am I going to be able to pronounce this? Omalizumab. A case report. Let's take a look at this for a moment. 59-year-old. Okay, so hold on a sec. This is from Turkey. A 59-year-old Turkish male patient with chronic urinary symptoms and the clinical symptoms of bladder pain syndrome, including frequency, urgency, nighttime urination, symptoms of UTI, but UTI and overactive bladder were excluded. These patients' symptoms were significantly improved with these two medications. This case not only provides new insights into the management of bladder pain syndrome, but also highlights the potential roles of mast cell mediated mechanisms into the etiology and treatment of this complex condition. So Montelukast, I want to get this right, also known as Singulair, is an oral medication that is what we call a leukotriene receptor. It is used for the long-term management of asthma and allergies. Now let's look at omalizumab, also known as Xolair. It is used to treat severe allergies by blocking an antibody called immunoglobulin E, IgE. This is not a rescue medication. This is used as a long-term therapy for moderate to severe persistent asthma. So that really, that doesn't come as much of a surprise because we certainly know that patients will flare during allergy season if you have a history of allergies. So using, Curtis Nickel and his phenotype proposal actually believes that there is an allergenic phenotype of interstitial cystitis. And so if you are somebody that struggles with allergies and you notice that your symptoms get worse during allergy season, using a medication that has an antihistaminic effect or other similar effects would be an interesting experiment. You can read about that over on the IC Network website in our discussion of phenotypes. Okay, now here's another study. I just want to go over this study because sometimes it's very easy for the medical system to start blaming us that maybe we're making these symptoms up. And that goes back to something that happened in the 1950s IC was first written about in the mid 1800s in the United Kingdom. You could read that definition today and it's still perfect. Different language, but it's still perfect. And then in the early 1920s, they invented a cystoscope. Dr. Guy Hunner was able to look in the bladder of IC patients. He found lesions, which we now call Hunner's lesion. Then during World War II, we had research that showed that children could be afflicted and men could be afflicted. So women, children, and men. And then all of a sudden in the 1950s, these two arrogant doctors published a case study of a young woman who had severe IC symptoms that they blamed on unexpressed anger manifested in the pelvis. In other words, they blamed it on her psychology. And from the moment that paper was published, literally until about 1990, many medical schools taught that interstitial cystitis was mental and emotional. Now, the blessing here is that's when the ICA and other experts got on board. They petitioned the National Institutes of Health. They got new research criteria put in, and the National Institutes of Health has since invested hundreds of millions of dollars studying IC and chronic prostatitis and pelvic pain. There is absolutely no doubt that this is a real condition that is not made up in somebody's mind. That we can have viral infections in the bladder, we can have bacterial infections in the bladder, we can have estrogen atrophy in the bladder, we can have a fibroid tumor pushing on the bladder, we can have a swollen vein, pelvic congestion syndrome, which can cause these symptoms. We can have pelvic floor dysfunction, pelvic injuries, nerve injuries, you name it, we can, okay? But still kind of floating in the periphery, there are still people who like to discuss psychosocial factors for flares. So we have a new study with a lot of top-tier doctors. So we've got University of Buffalo, another University of Buffalo, UCLA, University of Michigan. All right, let's see what they know. Let's just see what they've got to say here. Little is known about the cognitive affective factors associated with IC flares, even though pain is its cardinal feature and a defining attribute of flares, which are regarded as a global marker of illness severity. Disease activity is unable to explain flares because its pathophysiology involves altered pain modulation in the central nervous system, independent of peripheral pain. So what does that mean? That sometimes it's the central nervous system driving the pain rather than just the bladder wall driving the pain. So we sought to characterize how different psychosocial factors correspond with flare attributes. Subjects included 92 formally diagnosed IC or chronic prostatitis patients with refractory pelvic pain. Data completed as part of a baseline evaluation included the pain discomfort scale, a bunch of scales, yada, yada, yada. Psychosocial factors were broadly associated with multiple flare attributes. Their combined effect was the strongest for flare severity, with mood and pain-related suffering as predicted significant predictors. Okay, well, duh, if somebody's in pain, of course they're going to not be in a good mood. This investigation breaks new ground by linking psychosocial risk factors to multiple dimensions of pelvic pain flares. Further studies are needed to leverage this line of research to develop behaviorally based flare management programs that strengthen patients' self-regulatory capacity for reducing flares. Ugh. To the researchers, if you happen to be watching this right now, listen, I give you total respect. However, cause versus effect. We cannot deny the trauma any patient is going to experience if they are suffering from pain. Are they going to be sad? Yes. Are they going to be angry? Yes. Are they going to be depressed? Yes. Are they going to be frustrated? Yes. Is there a chance they might have some very, very dark thoughts? Absolutely. I did. We have to be very, very careful about not putting the burden of pain response back onto the patient, like they can control their pain by changing their mood. Now, I want to say this the right way, because some people would criticize me for saying that. Let me think about this for a moment. I was working with a patient from the United Kingdom like 2 weeks ago. And she flat out had doctors tell her it was all in her head, like offered her nothing. And her pain was off the charts severe. And she was crying on the phone with me. Just didn't know what to do next because they believed that this was all in her head, like she could control it. And that is so unfair because, again, number one, we have phenotyping now. So we don't even think IC is an incurable bladder disease anymore. We don't. IC is a pelvic pain syndrome for which there are many potential causes. Each one of you are an anatomical mystery to be solved. We have to get to what's driving your symptoms. It's really easy to what I call chase the symptom. People have chased their symptoms with bladder installations and Elmeron for decades and not gotten better. Why? Because that doesn't fix the underlying problem. We have to identify the underlying problem driving the symptoms in the first place. That's why we phenotype. So if, for example, you have been in pain, severe pain that's getting worse, let's say for 6 months, for God's sake, let them look in your bladder. You don't want anybody guessing you're in pain, you're suffering. You have to let them look. And let's see what they see. If they happen to see a Hunner's lesion, oh, okay, that explains it. Now we know why you're in pain. You got a dang wound on your on your bladder. Oh, I know what the other study that I was going to talk about was a new viral study with Hunner's lesions. So interesting. Okay, so anyway, if you've got severe worsening pain and you have not let the doctor look in your bladder, when are you going to do it? Because if it's something that's treatable, don't you want them to treat it so you're not suffering anymore? Don't be afraid of testing. We have a whole class, the IC 101 Master Class, episode 3 is all about the testing. You don't need to be afraid of a cystoscopy. A cystoscopy in your doctor's office is what I call a looky-loo. They numb your urethra, stick a stethoscope in, look at your bladder, pull it out, you're done. The only legacy from that is your urethra is going to hurt a couple of times after you pee. If they see something unusual, then they might ask to do a hydrodistension with cystoscopy. That's where they use some, that's done in the OR. You're under anesthesia. You should be under anesthesia because they're going to fill your bladder with fluid and stretch your bladder a little bit. And that's going to hurt a lot. That's why you're under anesthesia. This allows them to take a closer look at your bladder wall. Let's see what they find. Now, if you have all this done and they find nothing, great. If they say perfectly normal bladder, you're like, okay, then we got to figure out what's driving my pain because it's not my bladder. I will tell you, every single time I had a cystoscopy and a hydrodistension with cystoscopy, I have a baby bladder. It's perfect. Despite the fact that I was peeing every 30 minutes and I was crying in pain and kind of borderline having very, very dark thoughts. And now we know why so many patients have a normal bladder, because it's really not coming from your bladder. It's coming from your muscles and nerves. We now know that 85% of IC patients have a neuromuscular origin for their pelvic pain, as evidenced by very tight pelvic floor dysfunction, pelvic floor muscles, also known as pelvic floor dysfunction. And, you know, when I'm doing my coaching with patients, 'cause I work with patients every day doing coaching, you know, y'all are like finding a needle in a haystack. But man, I am persistent and I can ask a lot of questions. And I'm going to tell you right now, for the great majority of patients with pelvic floor dysfunction, we find that trauma. We find that trauma that set up the cascade for muscles to get tighter and tighter and tighter over time. So to tell a patient it's all in her head when it's actually a muscle injury, she can't urinate, that's really cruel. You are an anatomical mystery to be solved. You got to be very persistent. Don't just go walk into your doctor's office and say, give me a treatment. I don't care what it is. Please don't do that. Please don't let them put anything in your bladder. Man, you got to have a discussion. What do you want to do? Tell me what you want to do. Tell me how you think it's going to help. But in the end, your job is to focus on underlying causation. What is the underlying cause of my symptoms? What is my phenotype? I call this the chicken versus the egg dilemma. Which comes first, the chicken or the egg? And for us, it's which comes first, the bladder or the pelvic floor? For some patients, IC begins after a direct bladder wall trauma. If you've gone through chemotherapy, the chemicals of the chemo damage your bladder. Or if you've got severe estrogen atrophy and you're drinking Mountain Dew, that's a chemical injury to the bladder. Or if you've had an infection, infections damage the bladder. Even after it's treated, there's a lot of healing that happens. So here we've got a bladder wall that is structurally injured. It's screaming in pain. It's giving you the symptoms of frequency, urgency, pressure, pain. Your muscles are going to get tight to compensate for that pain. It's called the guarding response. Your body goes, don't move, it's just going to make the pain worse. So your body is always naturally going to try to get you to be still when you're in pain, guarding. So for these patients, especially when it's really easy to identify what the triggering event was, our treatment priority is to calm and soothe the bladder. And as we calm and soothe the bladder, the muscles should relax and release. However, that's actually the small percentage of patients. The majority of patients' symptoms begin with a pelvic trauma, but you have no idea. You might have fallen on your tailbone. You might have been a child athlete. You might have been an elite runner. You might have had a difficult childbirth. You might have had another surgery. So after that trauma, your pelvic floor muscles, let's just take a simple fall. When you fall, bam, all of your weight lands on your pelvic floor and you suffer a compression injury. So 150 pounds land on its little area right there. They squeeze everything. The muscles get compressed. The blood vessels get compressed. The blood vessels get broken. That's a bruise. Nerves get irritated. Okay. But when you're young and resilient, hey, your bladder, your tissues down there compensate. You know, you're young, you're resilient. Your body, you can get up and keep running even after you've fallen. Oh, it's wonderful to be a teen and in your early 20s. Your body's pretty good. But once you hit your 30s and 40s, you get what I call wear and tear injuries. And what we see are multiple injuries over time that just tighten the muscles consistently, a little bit here, a little bit here, a little bit here. And then all of a sudden the muscles are, bam, really tight. And this patient now has frequency, urgency, pressure, pain. Of course, to them, they're going, well, I got to have a bladder infection. So they go to the doctor. Doctor tests your urine. Your urine's clear. But let's give you antibiotics anyway, just in case. You take the antibiotics, doesn't get better. You go back to the doctor. Doctor goes, well, let's do long-term antibiotics. Doesn't work. You go back to the doctor 6 months later, whatever. Doctor goes, maybe you've got overactive bladder. Let's do some ditropan, detrol, mirabegron. Might help a little bit, but you're still flaring. You're still having problems. Go back to the doctor. Eventually, the doctor goes, oh man, I hate to break it to you. You got interstitial cystitis, this incurable bladder disease. Here's a diet. Here's some Elmeron. Here's an antidepressant. I'll see you in 6 months. And you, the patient, you're just so freaking happy to have a diagnosis. You bring it home. You absorb it. You come to the websites. You learn. Thank God we know what it is. And you do everything. You follow the diet. You take the Elmeron, which we now know is a mistake. You don't just take it for 6 months. You take it for a year, 2 years, 5 years, 10 years, 20 years, because you've been told you have an incurable bladder disease. But the problem is you've done all these bladder treatments, all these bladder installations, and you're not better. You still flare a lot. You're still in a lot of pain. Why? Because those bladder therapies will do absolutely nothing for an injured pelvic floor. Our therapeutic priority for the pelvic floor patient is to restore blood supply. Because the long-term problem with tight pelvic floor muscles is it squeezes everything, including blood vessels. And your bladder and your vulva and your rectum, everything becomes ischemic or ischemic, compromised blood supply. If your bladder is supposed to get 24 units of blood a day and it's only getting 10, are you going to have a healthy bladder wall? Of course not. That's the legacy of tight pelvic floor muscles over time. And there are some patients out there who go to physical therapy. They do physical therapy 3 to 4 times and they go, it didn't help, and they give up. You can't do that. Tight pelvic floor muscles make it difficult to pee. They make it difficult to have sex. They make it difficult to have a bowel movement. But what you're not seeing is they compromise blood vessels and nerves. So if you're one of those patients where you did Elmeron for years and you didn't get better, or you're one of those patients where they looked in your bladder wall was healthy, but you were still doing DMSO treatments or rescue instills, have you had a pelvic floor assessment? If you haven't, please go do that. Because I can tell you the pelvic floor physical therapy is the single most effective therapy out there for a wide population of patients. And that's proven in a National Institutes of Health study. 85% of IC patients have tight pelvic floor muscles. That is exactly why we no longer think of this as an incurable bladder disease. Now, listen, you go into old support groups, you go online, you read old articles, they're going to say incurable bladder disease. You got to understand this is new information. We've only been phenotyping for 5-6 years now. And even then, there's so interesting the people trying to undermine that concept. You know, I've been phenotyping as soon as we started doing it with Chris Payne. It's been stunningly successful in helping patients find the right treatments for them. You know, the American Urology Association has now adapted phenotyping. Now we all have a little disagreement on the different phenotypes. Curtis Nickel believes there's 9. The European Union has 12. American Urology Association puts them all together and says that there are 3. I use the system that focuses on 5. Doesn't really matter. The point I'm trying to make here is we just have to try to find out what the underlying cause is of your symptoms. Hold on, let me take a look here real quick. Sorry, guys, my throat is still messed up. You know, I can take a deep breath. I have no trouble breathing, but there is resistance. And my incisions from my breast cancer do not like all the coughing I've done. So they're pretty icky too right now. So I'm kind of it's been a rough SuperFlu for Jill Osborne, that's for sure. All right, hold on one sec. So I just have to scroll back here. Hi, Kirsty. Does D-mannose help for anyone? Only patients who might have a history of E. coli-driven symptoms. E. coli is going to do absolutely, I mean, D. manus is going to do nothing for Hunner's lesions. It's going to do nothing for pelvic floor. It's going to do nothing for widespread pain. The only window that DMSO, the only phenotype that DMSO, I mean, D. manus is going to help is going to be a GSM patient with a history of E. coli infections. And as Melly wrote, I take D. manus daily, and it's truly helped me from not getting UTI. That's where it works. Lori says, I use hydroxyzine, which has helped me so much. Yeah, hydroxyzine is an antihistamine. It comes in two forms, Atarax, known as hydroxyzine HCl, and Visceral, known as hydroxyzine pamoate. I took hydroxyzine for many years. I did my first IC conference. I had the doctor that I was sitting next said, hey, Jill, do you have allergies? I went, yeah. He goes, we got this new allergy med that we think is helping the bladder. You should try it. It was hydroxyzine. That was in 1993. It was in June of 1993. That was the year I did my first IC conference. And I found it quite helpful. But I think the reason why I found it helpful is because it also has a mild anti-anxiety effect. And I was very, very, very anxious and scared. I thought that I was dying of cancer. I mean, my pain was so severe. Even when they diagnosed me with interstitial cystitis, I just said, I don't believe you. I do not believe that I have a bladder disease. I believe that I am dying. And I demanded exploratory surgery, and they did it. I still remember the look on my gynecologist's face. He's like, really? And I went, oh, hell yeah. I think you missed something. I think I'm dying. And I had that surgery in September of 1993. And I woke up in the recovery room, and he said, Jill, we found nothing. You're not dying. That's how rough pain is. Pelvic pain, bladder pain is characterized by being relentless and difficult to ignore. It dominates everything. You can't think of anything else because your bladder is throbbing so badly. It on the McGill pain scale rates equivalent to terminal cancer pain. So many patients wonder if they're dying of cancer when they have this level of pain, especially over time. And thankfully, it is not associated with cancer. But whenever you have your diagnostic workup, they should always do something called a urine cytology test, especially if you were a smoker or you were exposed to a lot of secondhand smoke like I was. They can do a urine cytology test to look for cancer markers just in case, because every now and then they miss somebody who actually has cancer. The blessing here about bladder cancer is if you catch it early, it is considered the easiest cancer to treat in the human body. So if you have any doubts, ask them to do a cytology test. The odds are they probably already done it anyway. They just didn't tell you about it. But again, if you're a smoker, ask for a urine cytology test, especially if you got a lot of blood in your urine, because blood in your urine is a symptom of bladder cancer. Yeah. All right, hold on a sec. Kayleen says, I sound better. I sound better, but my throat's still bad. So, Kayleen said, I wish I could afford that, but it's what my urologist suggested for me to do. I can't afford UTI since I can't take oral antibiotics anymore. Yeah. Kayleen, G-Manus is actually very, very inexpensive. We have it in the IC Network shop. You shouldn't have a problem getting a G-Manus that might be $15, somewhere in there. I don't remember how much it is in our shop, but guys, don't forget, we're having our sale, 15% off. You can get everything in our stores on sale, 15% off through New Year's. The promo code is Happy New Year. Sue says, my symptoms started in the 80s. I wish they knew now I wish they knew then what we know now. I probably went over a dozen doctors that just gave me torture treatments like bladder dilations, urethral dilations, long-term antibiotic use, which has left me with very few antibiotics to treat anything. It took me over 35 years to get properly diagnosed. I thank Jill Osborne and the IC Network for helping me find the right doctor and also keeping me going until I did not give up to know that there's hope and actually stop getting treatments that made things worse. I was also told my condition was in my head and I would be a burden to my family. I could not see any future. Please support legislation that supports research. And there's so much more that needs to be learned about painful bladder syndrome, pelvic floor syndrome, and pelvic pain. Yeah, and this is the first time since the 1980s that we do not have dedicated ICU research into IC and pelvic pain, and it's heartbreaking. It took me 25 years to be invited to earn enough credentials and respect in the industry to be invited to participate in a very large NIH research study. And we were funded last year, and we were then canceled by the current administration. I was reading something today from people writing proposals for research grants. If you're trying to get federal funding, do not mention women in your study. Like, okay, you've made it clear you don't care about women. Well, screw you. I am also going to offer that, listen, you guys, I'm not left or right in that degree at all. I'm about access to healthcare and finding cures and treatments. That is my priority. And that is what I am always going to fight about. And I am so heartbroken to see literally the entire IC research. It's done. I don't even know if they're saving research samples. We have the largest archive of urine over time from the MAP Research Network. I don't even know if they've funded saving those. Is it all gone? Is it just all deleted? Who knows? Us women are treated as walking anxiety diagnoses, but never for chronic pelvic pain. Well, anxiety is always going to make the pain worse, and it is our responsibility to acknowledge that we have an issue with anxiety. When we do, I have anxiety disorder. I have anxiety disorder from childhood trauma. And I do understand that it is my responsibility to learn good anxiety management skills so that anxiety does not dominate my life. Christy said, I could not find your doctor's list on the website. Could you please guide you? icnetwork.org. And it is under here, let me look. It is under where is it? Oh, it's under the IC pull down menu, find a doctor. So if you go to I moved it. You go to the IC BPS Information Center on the IC Network website. You go over, if you just slide your mouse over that first pull down menu under the logo, you'll see it's third from the bottom. Now, it's very, very hard to maintain these databases. Very, very hard. We rely on you to tell us doctors that you really like and physical therapists that you really like. So if there's somebody out there that's really, really helped you, would you do us a favor and send us their name and address so that we can add them to our database? Vicky says, hey, girl. Well, hey, girl, right back at you. I hope you're doing well. Happy New Year. I am ready to say goodbye to 2025. That is for sure. Sue says, I also thought I was dying of cancer back in the mid-late 80s. There's just so little to know about the condition when you don't have an infection, and when you're in so much pain, you're just out of your mind, and that's what you think. And then they tell you it's all in your head. That's what they used to do back then. That's exactly why having fully funded women's health studies at the National Institutes of Health is so important. And that's the heartbreaking thing about what's happening right now. I was listening to somebody had recorded a man telling a woman that she was his property. And she asked for a divorce. He said, "You can't divorce me. I own you. You can't do anything. I own you." That, my friends, is what we have to fight about. Man, that's going back to the 40s. Anne says, what's the difference between a vaginal and a urethral flare? Well, location. The urethra is in front of the vagina. Urethral pain tends to be very sharp. It's a quick, sharp ow. Might feel like there's a drop of urine stuck in your urethra that won't come out. Vaginal pain is deeper, and it's behind the urethra. Vaginal pain can cause a lot of burning, especially if you've got estrogen atrophy and or bacterial vaginosis. Kayleen says, I need your thoughts. I got a mouthful from my urogynecologist saying I never even needed the PICC line for any infection. He's telling me to minimize my doctors, which I kind of agree with him. It seems like every winter is when I'm really struggling with pelvic pain, but I think it stems from sacral pain. The low back pain, PGAD, vulvodynia pain is too much to deal with. He said I might have to see a sports medicine specialist. I don't want to see anyone that doesn't look at my anatomy. Well, you know, Kayleen, your case is very complex. You have a lot of different symptoms. You have a history of trauma and injury. You have a history of nerve compression. And when I think of you, I think of a trauma injury patient. I don't think of you as a disease patient at all. I think of you more as a trauma and or injury patient. And I'm sure you would agree with that. So seeing a sports therapist is really a good idea because they're the ones who understand the injuries more. I think I've shared that, you know, I had pelvic floor physical therapy for several years at Kaiser Permanente because I'm a member of Kaiser. And I was having a lot of pains sitting down that was just getting progressively worse over time. And I got to the point where I could only sit 15 minutes at a time. And so everybody was saying, you know, at the general physical therapy clinic, this is just old scar tissue. You just need to stretch. So believe me, I stretched every day like mad. And the problem is I just got worse and worse and worse. And finally, one of the physical therapists pulled me aside and said, honey, we're not going to be able to help you. You need a sports physical therapist, because I was an athlete. And that was the best advice I'd ever gotten, because when I went and saw the sports physical therapist, it took him 5 minutes to figure out what my problem was, which was a bad SI joint. That 3 years of physical therapy, they missed that it was all an SI joint. And it turned out all the stretching they had me doing was exactly the worst thing I could have done. And I had so overstretched the muscles. My muscles on my left side literally didn't activate. I was walking like this. I had all my weight on my right side, none on my left side. I didn't know that. He had me walk up and down a hallway and he goes, oh, that's so weird, Jill. Do you realize that when you walk like this, you walk in arcs with every step? And I'm like, no. He goes, go down, walk again. I walk back to him. He goes, yeah, man, you're definitely favoring one side. I'm like, I had no awareness of that at all. And then he did a couple of things. And then he said, yeah, it's your SI joint. It turned out that my sport, which was tennis, I was number one on my tennis team in college. And then I played professionally. I have the tennis injury. I have the same injury that Yvonne Lendl had. That's why my muscles stay tight, is fundamentally my joint is unstable. And that is the most important question you ask your physical therapist over time. Are my muscles responding to therapy, or are they Or are they always locking back down into tension? If your muscles are always tight, no matter what they do, we got to figure that out. That doesn't mean the physical therapy has failed at all. It means that there's something else happening in your body that is keeping those muscles tight. Could be having one leg longer than the other. So you're walking like this, you're walking tilted. Again, when you're young, your body can compensate, but wear and tear hits in your 30s and 40s. And finally, we see what happens to years of walking with one leg longer than the other in a tilted pelvis. Or you might have a funky hip, or you might have a funky ligament, or you might have a broken tailbone, or you might have a bad foot or a bad knee. So if your muscles stay tight, that's important to know. Again, it doesn't mean the physical therapy failed. I'm sorry, hon. Breaking Through Chronic Pelvic Pain is the book. This is the book you get. The author died this year. We may have our last copies. I think we're down to like 15 copies. Get it. Fantastic book for anybody with a complex injury. So I was working with a patient probably a week ago. I was able, with this flu, I was able to talk for an hour a day and then it was 2 hours a day. And now I'm maybe at 3 hours a day. We'll see. Anyway, so she'd been diagnosed with IC. Bladder therapy is not working. Referred to physical therapy, tried physical therapy. She didn't feel it helped her, so she gave up. And I'm like, and that's when I stopped her. I went, now, hold on, wait 1 second. You went to physical therapy. What did they find? Oh, well, my muscles were really tight. I'm like, okay, that's important. So you tried physical therapy. What happened? It didn't really help. So I gave up. Don't give up. And then I asked her, she's like, but it's bladder. And it's like, well, but they looked in your bladder and your bladder is healthy. And more importantly, you're not responding to bladder therapy. She called because she wanted to try a new bladder installation. It's like, why? Your bladder is healthy. They've looked at it. But here's what we know. You have very, very tight muscles. She's like, yeah, but I don't really like physical therapy. I don't really want to do it. It's kind of embarrassing. And I'm like, all right, now hold on 1 second. And so, I'm kind of doing that educational explaining it all with ischemia and stuff like that. And I'm like, is sex painful? She said, it's terrible. I said, how long has sex been painful? She said, my whole life. She said, she's never not had painful sex. And it's not a little pain, it's a lot of pain every time she tries to have sex. From day one, when she lost her virginity, bam, painful. It's never gone away. I went, honey, you have vaginismus. You know what that is? She's like, no, that means that you have muscles so tight that it's so tight, bam, you can't get anything in there. And that's what her physical therapist and doctor said. Her muscles were so tight, they could not get a finger inside her vagina. She was locked down. It's hard as a rock. And then, we kind of go through our history and we find trauma. We find a really significant history of injury and trauma, which created the foundation for all of this. She just didn't know. She was kind of thinking this is a bladder disease. And it's like, guys, they look in your bladder and your bladder's healthy. Maybe it's not a bladder disease. Maybe it's neuromuscular. Hold on a sec. Sue says, I love you, girl. Thank you for my life. And I mean that always too. You've helped me too, hon. Every single one of you, you've helped me during, especially the last couple of years, through very, very dark times. Christy says, thank you. Lori says, I wonder if a sports medicine interventional pain management doctor would help Kayleen. I think it's a great idea. I would definitely go. Kayleen says, would they do pelvic exams or just gait tests? They would do gait tests more than anything else, because you're not going for pelvic floor physical therapy in the sense as we're going more to try to understand the overall health of your pelvic area and your legs and your knees and your feet, et cetera, et cetera. So generally, a sports physical therapist does not do pelvic exams. Your ability to describe your symptoms gives them a roadmap. So you've got to go back. We talked about this, girl. Have you made a list on paper, not on your phone, on paper, of all of your symptoms that you can hand to them? I want to know left side, right side, front, back, tingling, pins and needles, pain. Where is the pain? How often does it happen? When is it worse? When is it better? Are there any weird things that happen when you're in pain? Do you ever have a sciatica, shooting pain, anything, vibration? Your ability to describe your symptoms gives them a roadmap on where to look. And that is very, very true with the sports physical therapist. And you are a trauma patient. You're going to tell them that you're a trauma patient so that they can understand the complex dynamics of the trauma you experienced and what that would have done, what that would have touched, et cetera, et cetera. Joan said, I had a urologist do a urethral stretching during a terrible flare. It made me so much worse. Still in pain, and it's been months. Joan, they did something called a urethral dilation. Man, that's really old school, my friend. That's really, really old school. I had urethral dilations in the 70s when I was 13, 1973. That's what they did. That was the treatment back then is, maybe it's just her urethra. Let's just stretch it open. So I endured dozens of urethral dilations. Many, many older patients like me went through urethral dilation. Today, we ask ourselves, why is this tube narrow? What has caused this tube to get so narrow and tight? And the answer, of course, is the pelvic floor. And so, Joan, that was kind of like a doctor's old school Hail Mary. Like, maybe this will help. Let's try it. But just understand, we just don't do urethral dilations anymore. The only reason to do a urethral dilation is if you can't pee. And that it's basically forces your urethra open. We had at a conference probably 10 years ago at an American Urology Association conference in the IC class. And it was, where was that conference? I don't remember where it was. Might have been no, it wasn't Los Angeles. Anyway, a foreign doctor asked the IC panelists, and the panelists were the IC teachers at that time were Rob Mulder, Rob Evans, and Christine Whitmore. And a foreign doctor came to the microphone and said, do you do urethral dilations? And one of them said, no, we don't rape the urethra anymore. That's the exact words. No, we don't rape the urethra anymore. That is a traumatic procedure that forces open the urethra. Instead, we have to ask, gee, why would it be narrow in the first place? So anyway, so the question now is, why are you still in a flare from it? Urethral pain. I have a really good article on the IC Network website called The 7 Causes of Urethral Pain. The most persistent cause of urethral pain is estrogen atrophy or bladder infection or tight pelvic floor muscles or a chemical sensitivity to something as simple as a laundry detergent or a pad, menstrual pad, or an incontinence pad, or even fabric softener. So if you are continuing to have urethral pain, I would tell you to go over to our website and search for urethra and read that. Joan says, I'm not sure if anybody's ever asked this question. Does anybody find that weather temperature can affect their IC pain? Oh, absolutely, hon. Kayleen was just saying earlier, winter is absolutely the hardest part of her year. That's very, very common. Extremes in temperature, whether it's cold or heat, are certainly going to exacerbate symptoms. It's stress on the body. It's just physically stressful. Kayleen says, I might be in the hospital in less than 2 weeks anyway. I need to get back to my own self, but I'm so weak. I'm not allowed to do pelvic floor physical therapy until I get help. I keep telling everyone my mental health treatment that I need lower back massage. Well, honey, they can't do lower back massage. Okay, I know you've been writing everything down on your damn phone. Stop it. You can't give them their phone. That doesn't work, Kayleen. You have to put it on a piece of paper and hand it to them to go in your medical record. You're creating a barrier. I know you like your phone, girl. We've talked about this before many times. It is no substitute for a piece of paper handing it to them. You just have to do that. I don't know. Can you print it out from your phone on a printer? If you can print it out on a phone on your printer, you're good. If you cannot print it out, write it down. Hello, Deborah. Nice to see you, honey. Hello, Joanna. Hope you're well. So we started our meeting talking about the SuperFlu. They are now. Hello, Deborah. Nice to see you, hon. So we're live streaming right now on YouTube and Facebook. And we have about 40 people watching right now. So let's just go over this SuperFlu again real quick. For those of you who came in late, the H3N2 subclade K influenza A mutation is a very, very severe flu that is not covered by the flu shot. And so where I live here in California, the week before Thanksgiving, they started publishing articles telling people about this variation and predicting very severe, very dangerous flu season, that this is an unusually severe flu. Not like the flu from last year. This is much, much worse. And so I got it at Thanksgiving, and I'm a month later, and I'm still coughing. So it's very, very contagious. So we think somebody took a plane flight, brought it to the big family dinner, and Saturday after Thanksgiving, everybody in my family got it. 2 of us got it the worst. I was one, and then another one got it the worst. So it starts with what they call the razor blade throat. It's such a severe sore throat. You can barely swallow, and you feel like your throat's been cut open by razor blades. So that's how it started for me. On the Saturday morning, I felt a tickle. By Saturday night, I could barely swallow. I went to urgent care Monday morning because I thought it was strep. The strep test was negative. And they gave me antibiotics because the doctors at urgent care really didn't understand quite yet that this was the flu either. They were still operating under the assumption that this was maybe a bacterial infection. So the sore throat lasted 3-4 days, and then the congestion started. And the congestion, I haven't had congestion like that since I was a kid. I am talking green mucus, green chunks of gunk coming everywhere. And then very quickly, a very deep, wet cough. A very deep, wet cough with green coming out. Okay. So, I was on amoxicillin. They'd given me amoxicillin. I think, you know what? You're good. Well, that Friday night, I was watching K-pop Demon Hunter again. I happen to love that movie because I love the music. And right in the middle of it, my heart went bonkers. Like I'm laying there watching the movie, and all of a sudden my heart was, like 200 beats a minute. It's horrific. Now, because I am known for having this reaction, I went and got my heart medicine, a little bit of low pressure, didn't touch it with a 10-foot pole. Called 911. I was too ill. I was too weak. You're also very, very weak. I mean, just walking 10 steps is hard. I knew I needed to get to the ER, so I called 911. And here's what was hysterical. So, it's like I got myself out of my recliner. I put some clothes on, got my charger for my phone, called 911 because I knew they'd be there in 5 minutes. And so I opened the front door and the fire truck's here and the ambulance is here. Again, it's on a Friday night. And they from the street, they go, "Is this for you?" And I went, "Yes, it is." And they said, "Just get in the ambulance." They didn't even come into the house. They just said, "Just get in the ambulance." And so I just shut the door. I had my bag, got in the ambulance. And I was shocked. It's like they were like, "Jill, you're the fourth person we picked up in 2 hours with us." And then they put the heart monitors on and they saw that I was going in and out of AFib. So when we got to the hospital, I was going in and out of AFib, and it was very pernicious AFib. It took a lot more medicine to stop, and they didn't want to shock my heart because they didn't want to potentially dislodge a blood clot. They didn't know how long I'd been in AFib. So anyway, okay, we get that calmed down, and they go, "Yeah, there's a really, really bad virus going around." They took X-rays. I had pneumonia in my left lung, mild pneumonia, but it was still there. So I walked out. They switched me from amoxicillin to Augmentin. And I had to start a blood thinner again for the AFib, which I hate because it always gives me GERD. Okay. So at 4 a.m, my sister drives down, picks me up. We come home. And I'm like, "You're good, right? That's it? That's the worst?" Mm-mm. The worst was Sunday morning because my sinuses started bleeding. Now, this was not a bloody nose. Like, my sinuses just bled. And I was I literally went, "I might be dying. This might be what happens when people die." So my brother-in-law drove me back down to the ER. I just said, "You got to take me back down." And I was literally crying in the car. I was crying at the ER. I did not understand why I was so ill. And they took me back, and the ER doc comes in, and I'm just like, "What is this? Please help me understand what this is." And she said, "Jill, you've got the really, really severe virus, and you have pneumonia." And so she gave me a third antibiotic. But thankfully, my blood test and my white blood count was very high. I mean, it was very obvious I was fighting a severe infection. Very obvious I was fighting a severe infection. So anyway, urgent care, ER twice. Okay. Now, it has been 3 weeks since I've been to the ER. I am still sick. I mean, I sound better, but I'm telling you right now, my throat is messed up. It's not razor blade throat anymore. Now it's that inflammatory thing that happens after you have the flu where you just cough all the time. So I have a little wheeze, but I can breathe. So the pneumonia is better. But I guess the point that I'm trying to say here is that I had no December. People are going to ask me about Christmas this year. I'm going to go, "What Christmas?" I was sick every single day of this month, and I'm still sick 4 weeks later. And I just beg of you. I mean, people are dropping like flies here. I've worked with IC patients who have it. I've got multiple friends who have it, and they are in bed in horrific shape right now. You have got to protect yourself. This is a SuperFlu. They are calling this a SuperFlu. If you have anybody in your family who has a sore throat, do not go to their house. You will get it. If you have anybody who's very sick, keep your distance if you can. But if they are in your home, it's probably going to hit everybody in your home. So go to the ER early, go to urgent care early, stay very, very hydrated. You got to drink a lot of fluid. In fact, I haven't drunk enough fluid today. That may have played a role in my AFib too. But the other thing that just shocked me is I was doing some research yesterday, and it turns out that viral infections, COVID is known for causing tachycardia and AFib, and so is influenza A. So I find myself going, God damn it. Leave it to me to get two viruses that physically damage the nerves in your heart. So I just pray and hope they heal. So I don't want what happened to me to happen to you. So you really have to protect yourself. And on that note, I need to go drink some water to stay hydrated. So let's take a quick pee break. I'll be right back. All righty. Okay, so my goal is to drink all of this in the next half hour. And I probably won't be able to talk tonight at all after talking here. Good night. So Anna says, my husband did get a bad flu. It's probably this one you're talking about. Yeah, probably. You know what? Let me go get the cough lozenge. Hold on. I've been doing these Ricola honey herb, and they've been good. The other thing too, kind of fair warning, is that because your throat's so bad, you really don't eat or drink the first week very much. And I've had a lot of really persistent nausea, but that's from the blood thinner. So I can only eat small meals right now. So I will, what am I going to have? I'll probably have a turkey salad sandwich, maybe. Kayleen says, I always remember the heat is bad for IBS and the cold is bad for fibro. Nellie says, I live in a 55 community. Last year, if you were out and about coughing and breathing on people, I know. That was like the thing when I was caring for my elderly parent. It's like, I especially during COVID, I was just so focused on not letting them die of COVID and the absolute disregard of people walking into the home of people who are elderly or sick when they're sick themselves just shocked me. It's like, why would you do this? Why would you expose a 100-year-old to what you have right now? And I had people do that. And I think the reason why the doctor, my dad's cardiologist said, what they saw the most was home workers bringing COVID into the homes of people who were homebound. And I think that's how we all got COVID right when they died. It's a care worker brought it in. Melly says, yeah, no regard at all. I mean, it's just very, your perspective on life changes as you get older. It just does. You see things when you're older that you don't see when you're younger. So, for example, the other thing that just shocked me was, like, my mom was a love bug. She loved everybody. I never ever heard her say a bad word about anybody. She was an elementary school teacher, and she gave up so much for family members, when they were young. And then when they got old and grew up, man, they just forgot her. They just forgot her. And I feel like it was a real callous disregard of the elderly in the family. Just an absolute callous disregard. Think they gave you 50 years or 40 years or 30 years or 20 years. They loved you unconditionally. And now you can't even be bothered to call once a year and say, thank you, Grandma, or thank you, Mom, or thank you, Auntie. I kind of have a beef with that. Casey said, is it common to have blood in the urine with IC? It's common to have microscopic blood in the urine. It's not so common to have visible blood in your urine. That's not common at all. If you have visible blood, granted, you know what? I do not know what happened to my mascara here. I feel like my eyes being weird. Anyway, I've worked with many patients who pee bright red blood. Okay. Bright red blood is when I say many, I mean probably one a year for the last 30 years. But they're very memorable discussions because it's so incredibly unusual to pee bright red blood. We will have microscopic blood, but not bright red blood. And anytime a patient has bright red blood, that is an immediate call to your doctor. And the first thing they're going to do is rule out infection, because bladder infections can cause bleeding. Okay, but if you don't have infection and you're still bleeding, your step number 2 is they need to look in your bladder. Like, we need to look and see what's bleeding. Do you have a lesion on your bladder wall that's bleeding? Or maybe is it your kidney that's bleeding? We don't know. And what I have found absolutely disgraceful are, I can remember I worked with a patient maybe 6 months ago who literally was consistently peeing bright red blood, and her doctor didn't do a workup. It's like, Well, what has your doctor done? I mean, it's not normal to have red urine like that. And he's like, oh, it's just IC. And it's like, no, that's not IC. That is not IC at all. That might be a Hunner's lesion bleeding, but for God's sake, we don't ignore it. They gotta go into that and try to understand where that blood is coming from. And I told her, I said, listen, you need to get back into that doctor's office and you need to be demanding here because this is bad. Whatever is happening, something is happening that has to be understood a little bit more because you don't normally have bright red blood in your urine. And we have to figure that out. And if you have a lesion on your bladder wall, they can cauterize it. You know what they do when you've got a bloody nose that won't stop bleeding? They cauterize it. They can do that in your bladder. They can cauterize a bleeder. So they need to do that to stop the bleeding because that patient that I was working with was anemic. She had lost so much. That's why she called, because she was, if I remember correctly, she was going to do iron infusions. And she was really worried that the iron would irritate her bladder. And then we kind of got into it a little bit more. And I was just stunned at what clear, callous disregard the doctors were showing to her. A lot of people ask, well, why would you have microscopic blood in your urine? And when we think about the phenotyping, that's going to be the most common in Hunner's lesions or in patients with estrogen atrophy or chemical injury of the bladder. Because the bladder wall is broken, urine is now getting into the meat of the bladder wall itself. When that happens, the immune system kicks in and sends white blood cells to your bladder wall to kill the invader. You've got urine going through the hole into the bladder wall. Your body doesn't know what that is. So your body is saying, you know, your body's calling your army, your white blood cells. They swarm the area. They come up in the blood vessels, but they're inside the blood vessels. So how do they get from the blood vessels into the tissue to kill the bacteria or to kill the invaders? Well, these little tiny capillaries in your bladder wall open. They open to release the white blood cells into the area. And when they open, they also release red blood cells. And that's probably the source of the microscopic blood. I got really good pictures that I can show you on Facebook. I can't show you on YouTube because Facebook is using my streaming software, where YouTube is just a camera and a microphone. Melly says, shame on the doctor. Oh, hell yeah. Kayleen said, I told my mom I wish Jacob Marley could tell me there's 3 ghosts coming so that I could relive those Christmases with my grandparents. Yeah. You know, guys, like I've had a real change of perspective about the Christmas. I had been very blessed that we had never lost a family member. Other than grandparents. Like everybody on both sides of my family lived to their mid to late 90s or 100. So I had never personally experienced directly death other than the death of a boyfriend. And I was not prepared for that. That was 2 years ago when my dad lived to 100 and a half. My mom lived to 94. And I read a really great essay on Twitter that I actually shared on my Twitter feed, that for children, Christmas is a glorious holiday. It is. Presents, songs, happiness. For a child looking at Christmas, it is, as long as it's a healthy, functional home, Christmas is glorious. Christmas was always glorious for me and my parents. especially when we were younger and my grandparents were alive, man, and my aunts and everybody, they made sure that the kids were the center. Now I kind of understand why, because when you're older and you've experienced loss, and now we have an empty a chair or two or three during the holiday, and that person who always brought you joy and the person who always thoughtfully bought you a present or you bought them a present, when they're gone, you feel that loss even more. And so Christmas to me, I remember my first Christmas, I put on a very brave face at my sister's, but I'll tell you, I sobbed driving home. I just sobbed. And then last year was my second Christmas and I did better, but I still cried all the way home. And but my sister cried too. We realized she actually cried more than I did. And as we were talking about it after the fact, we were just like, okay, we have to approach Christmas in a very, very different way now, because it's hard when you've lost people, and my heart just broke. It breaks for anybody who's facing their first holiday without their loved one, much less multiple loved ones, like, Rob Reiner's daughter and son, to lose both their parents right before Christmas. I can't even begin to imagine what they're going through. So I think I now understand why my mother and my aunts, everybody made Christmas about the children, because that's the easiest way to get through it. That if you help the children laugh, you kind of forget your own sorrow a little bit. So anyway, I used to love Christmas. I don't love it right now. I don't. It's hard. It's just hard and painful. And I was home because I wasn't feeling well. And, I cried Christmas Eve a lot, off and on all day, just thinking about being alone, but it was better on Christmas Day. And then I kind of have a new guy friend. He came over and we played games on Christmas Day and we had a great time. So anyway, Cece said, how many of you guys also have been diagnosed with endometriosis? It's a huge subset of patients. We call IC and endometriosis the evil twins. And so we don't have an exact figure, but I'm going to say maybe 30% of women with IC have endometriosis at the same time. That's a guess. It's a pure guess. It might be much higher than that. I don't know. I don't think it's lower than that. I think, if anything, it would be higher than that. Kayleen said, I had stage 2 removed in 2022. They put a Mirena IUD in, and unfortunately it stopped working in December. I got it replaced back in July and I feel better. We're trying to save my fertility because I just want one baby. Endometriosis, there's a very good nonprofit. The Endometriosis Association is absolutely fabulous. I did a big interview with their founder quite a few years ago, and she's still there now. One of the things that she taught me is that endometriosis is triggered by exposure to hormone mimicking chemicals, specifically dioxin. And it's a very, very interesting story. So the Endometriosis Association got started in the 80s, right around the time that the IC Association got started. But they had an early breakthrough. As they were going through the medical journals, they found this little obscure article on dioxin causing endometriosis in monkeys. And it was a fascinating, a tragic study. You guys remember, I gave up my career in drug research because I love animals, and what I witnessed, I simply refused to do. And so I walked away from a very lucrative career making medication because I refused to torture animals. I just did. Okay, so what this study was done by the dioxin industry. So dioxin is considered the single most toxic chemical ever made by man. It happens when you burn plastic. And so think about, you go back to 50s, 60s, what did they do? You burned Christmas wrap and plastic in the fireplace. And or the big waste facility, they would burn plastic. Well, when you burn plastic, dioxin is released, and it then goes into the environment where it settles everywhere. It's just spread throughout the environment. And it will settle on grass. So if they're burning plastic near dairy and the cows are eating the grass, the cows are now eating the dioxin. And they're eating so much grass, the dioxin is now being concentrated in the cow's body, where it is then found in high levels in milk. And what do we feed our children? And what do we drink? Milk. And so dioxin has a very insidious way of getting into the environment, then getting back into animals and people. So anyway, the plastic industry was trying to prove that dioxin was safe. So they did a study of monkeys where they gave them increasing doses of dioxin. And finally, one died. And when they did the autopsy, this little monkey was filled with endometriosis. Filled. And these industry researchers, much to their ethics, published a paper in which they concluded that dioxin could cause endometriosis. I'm sure the plastic industry would have tried to suppress that if they could have, but it did get out in this little obscure journal. So anyway, the initial team at the Endometriosis Association contacted, I think, the National Institutes of Health and said, can we please learn more about this? And they found, and I might have the sequence of events wrong, but they found that they were going to either kill the monkeys or sell them off for other research. And so the endometriosis people said, before you do that, can we do laparoscopies under anesthesia to see if we find more endometriosis? And that was granted. And they did indeed find endometriosis in every patient, every monkey exposed to dioxin. And the more more dioxin they were exposed to, the more endometriosis they had. So it was a dose response. So they learned very, very early that certain chemicals, which are estrogen mimickers, somehow facilitate the growth of endometrial tissue. We did not have any kind of breakthrough like that in IC because, of course, now we know IC isn't a disease. So for most of us. Every couple of years, another chemical is now added to that list as it is known to cause endometriosis. So there is a master list somewhere, I don't know, a dozen, I don't know how many chemicals are on that list, but there are plenty. So one of the things the Endometriosis Association tells everybody is you got to clean up your house. You cannot leave chemicals in your home anymore. Anything that has the potential of being an estrogen mimicker. And that means no room sprays, no scented candles, especially cheap scented candles from China. where a lot of these chemicals are coming in with no testing. No, you can't use oven cleaner, anything at all like that, man. You got to clean all the chemicals, remove all the chemicals from your home. This means no ant spray. This means no pesticides. It means going back to nature. Like, I have a pet service that comes out and they spray concentrated orange something outside. I don't use any of those chemicals in my home. Any. I mean, and if I have ants coming in, I'll put a green dish soap and cinnamon around where they're coming in, and that it usually stops them. But anyway, so I have an article over on the IC Network about a section about cleaning up your home and getting rid of the chemicals out of your home, because that is undeniable research. Now, is that the only cause for endo? No. I'm sure there are other reasons why, but it is a very well-known cause. And the other thing the endometriosis research has showing is you might not have been the person exposed. It might have been your mom. It might have been your grandmother, that it actually appears to pass down in some way. This is, again, why we need a vital, critical research on women's health issues at the National Institutes of Health. And a lot of that research is now being discouraged because apparently women don't even get me started. Let's just say there's misogyny happening. Women's health is not as important as men's health, apparently. Okay, hold on a sec here. Diane said, I'm wondering if anybody has steroid injections into the bladder while awake, not put under in the operating room. It's so painful. Very rarely, hun. No, you would normally have that as an outpatient procedure. You would not do that awake. Did you have a doctor do that awake? Damn. That seems quite cruel to me. Cece said, in my case, it never affected my fertility. It was in the back of my bladder, adhesions in some areas of the uterus and the colon. After diagnosis with the laparoscopy, I was put on the Lupron injection. Here, hold on a sec. I had bad side effects, stopped, and next year I was pregnant with my last and third baby. I haven't been in treatment since then, and I'm in severe pain. I was just referred to MUSC to see an endometriosis specialist. Well, yeah, I mean, normally what they want, I mean, the fundamental problem with endometriosis is it's endometrial tissue, or similar to endometrial tissue. And as that endometrial tissue migrates throughout the body, it still has the potential of bleeding whenever you have a period. And blood in the body cavity is very, very painful. Blood is meant to be in a blood vessel. It's not meant to free float through your belly. And so wherever you have endometrial tissue, if it weeps blood, that can be very, very painful. Now, I will say that I have not looked at the latest endometriosis research in a couple of years. I should. We definitely need to do an update on that. So, and the other big challenge, as you just explained, Cece, and for Kayleen too, is that, endometrial tissue is tough tissue. It attaches to things, it wraps around things, it restricts blood supply. I mean, so it can wrap around the bowel and make it hard for stool to pass. It can attach to the bladder, and over time, it kind of eats its way into the bladder. And so it starts on the outside, and then it just kind of burrows into the bladder, and then it can burrow all the way into the bladder cavity. And so, it is absolutely real that there are patients out there who have had endometriosis as the underlying cause for their bladder symptoms because it had attached to their bladder. It's a bitch of a condition. And, just kind of like, You would think that we would learn. You would think that we would learn that tobacco causes cancer. You would think that we would learn that Roundup is linked to lymphoma or whatever other cancer that causes. You would think that when this is so firmly established that we would change as a society to protect people, but we don't, because it's all about the money, honey. The companies, they don't care if they're going to hurt us. They don't care if they're going to give us cancer, man. They're just trying to get your money. And that's the part of that's one reason where we in America fail. You know, I write in our book, The New Diet Guide, and this is absolutely true. We have patients who, when they travel, especially longer trips, they travel, if they can afford it. If they travel to Europe and they're there for 6 weeks, their symptoms go away. I've had many patients call me, say, "You're not going to believe it. I went on vacation. I was fine. I could eat anything. Like I thought I was cured. And then I come back and the symptoms come back." Like, what is that all about? Now, is it a chance that they're on vacation and they're very relaxed and happy? Yeah. No stress. That's a good thing. But I think, and I talk about it in the new book, that this also speaks to the much better, less chemically driven food in Europe than in the United States. Is that playing a role in some of our symptoms? Well, it sure as hell is playing a role in the high cancer level we have here. Titanium dioxide. Titanium dioxide is a white food coloring. It's in a lot of the pills that we take. It's in Tic Tacs. It's in anything that we eat that's meant to be white. It is a food coloring. Well, it turns out that titanium dioxide, when it's broken down, travels through the body, including to the brain, where it can cause cancer. Which is why the European Union has banned it. Most of the world has banned it, except the United States. Because the difference here is, in Europe, the drug companies are required to prove it's safe before they can go to market. In America, the drug companies get a pass. They get to say generally recognized as safe without proving that it's safe, and to release it to the masses. And then when people start getting sick from it, that's when supposedly the FDA kicks in and that regulatory effort kicks in. But the question is, does it kick in? Well, Elmeron's still on the market, even though we know it can cause blindness and inflammatory bowel disease. The researchers who did the last big study that showed it didn't work in 2015 thought it'd be pulled from the market quickly. 10 years later, it's still being sold, even though it's known to cause blindness. Not in everybody, but in a big chunk of patients. That is, in my opinion, an FDA regulatory failure. So we have to be much more protective and assertive. That means that we don't eat junk food, especially junk food from other countries, because you just don't know what's in it. It means that when you go to the store, you buy real food and you make real food. You don't get a pre-made food from another country, potentially. Although I would certainly get like pasta from Italy. That's a win, because they don't spray glyphosate on wheat like we do. They spray phosphate on wheat the day before it's harvested to help it dry out. And here's a chemical that is found in Oreos. It's found in almost all the crackers on the market and cereal on the market that has been linked to devastating health effects. People have gotten big settlements because they've developed cancer from glyphosate, and yet they're spraying it virtually on every wheat that's harvested in the United States, unless it's organic wheat, And so if I have a chance to, I will only buy organic flour. Usually Bob's Red Mill organic flour. And if I can if I'm going to buy pasta, I buy the Italian pasta. It's like, when did we stop caring for people? When did we put dollars ahead of the lives of our neighbors? When did that happen? That's a fundamental shift between the 1950s and 2025. And that's really the start of the industrial food industry. I mean, I could go on and on about that. It's just heartbreaking what we've seen. So just clean it up. Hey, that's the resolution for 2026. Improve your food quality. Go organic whenever you can. No junk food. If you're going to do alcohol, granted, we know alcohol irritates the bladder. Do a de-alcoholized alcohol. That's what I do. I get non-alcohol beer now. Stella Artois, it's great. And Guinness beer, it's great. And you don't have the alcohol that's toxic to your body, the alcohol that's known to be linked to cancer. And the only thing that's potentially going to irritate your bladder is the acid, but you can do a little bit of pre-leaf in there. Hi, Paula. Anybody else have any resolutions there? I would love to be at the gym every day, 5 days a week. I'd love to be at the gym. But I haven't been to the gym in a month now, because the rule is, can you work out when you're sick? If it's above the neck, yes. If it's below the neck, no. And so when you have the flu and you're coughing and pneumonia and things like that, you don't go work out. Number one, you're gonna infect everybody at the gym, which would be cruel. But we have to let our body heal after these big bad infections. Oh, so let me find this virus study. Hold on a sec. Yeah. Here it is. Okay. So it was a study. So remember, researchers in Europe were the first to link viral infections to the development of Hunner's lesions. Because one of the greatest mystery in the IC world is, why do lesions happen? Why do roughly 5 to 10% of the IC patient population have these big visible lesions on the bladder while the rest of us don't? Like, what is that lesion? Where is it coming from? And so about 10, 12 years ago, European researchers were studying the urine of patients with lesions versus patients without lesions. And they kept finding viral signatures, viruses. That was very, very interesting. And what they found was Epstein-Barr, the mononucleosis virus, and another virus called polyoma. So they started giving us more research identifying active viral infections in some IC patients. Well, and we were talking about it. You could go back, 10 years and watch the live streams. We were talking about it back then. It's like, what's this? We've never had viral infection before. So for 5 years, the American IC research community said nothing. They said nothing about it. And we're like, what do you think of the viral theory? This is info. This is good info, because if it's a virus, maybe these patients can do an antiviral. And then COVID hit, and they found the COVID virus in bladders of some patients. All right. So anyway, so what we didn't know was that the MAP Research Network at the National Institutes of Health, they were doing their own viral study because they had all these urine samples over time. And they found it too. They found virus too in roughly 5% of IC patients. So that was huge. And it's funny, if you look at the European guidelines for IC, they say to actively screen for viral infections, and so, which we don't do here in the United States. And I actually emailed one of my contacts in Europe and said, so what do you do when you find a virus? They said, nothing, we don't know what to do. Like, great, okay. Then we had a couple more research companies that were research studies that were using next generation DNA urine testing. And if they found virus, they then gave that patient an antiviral and the patients got better. Okay. So fast forward to this study. So this is a study from Taiwan. And okay, the title is very academic. HLA-DQB1 mediated B-cell epithelial crosstalk drives Epstein-Barr virus associated inflammation in Hunner IC. So Hunner IC is a chronic condition marked by persistent pain and inflammation. So they use RNA sequencing and RNA sequencing, which revealed strong Epstein-Barr response signatures. And then they were able to see that in that environment, B cells secreted interleukins and a variety of other things which activated prostaglandin synthesis and stress genes in epithelial cells. Anyway, among differentially expressed genes, the HLA-DQB1 was most strongly induced Epstein-Barr positive Hunner's IC. It's a gene mutation. So in other words, the virus causes a gene to mutate in the bladder that causes a significant inflammation. Our integrated analysis supports a model where Epstein-Barr infected B cells perpetuate Hunner's lesions, highlighting a tractable axis for precision therapy. Now, isn't that interesting? Very, very, I mean, it's about time. You know, the challenge that we have is that the mainstream organizations like the American Urology Association and the National Institutes of Health, they're very, very conservative and they're very evidence-driven. They want to see the research. They want to see all the research before they jump in and say that's playing a role. But there kind of comes a time when, yeah, it might not be a big double-blind, placebo-controlled, multi-million-dollar study. But when you have a substantial population of smaller studies, like that study, which found a very clear pathway for the Epstein-Barr virus causing a mutation in the genes of the bladder wall, resulting in the development of Hunner's lesions, maybe, just maybe, we now need to consider antivirals more strongly. And that's exactly why lactoferrin has a place. You know, we had a research study come out last year which showed that lactoferrin, which is a normal part of our immune system makes lactoferrin. We have it right now in our eyes and in our vaginal fluid and in our secretions. Unfortunately, as we get older, our lactoferrin levels drop, but lactoferrin is considered a front line of defense in the human body for infections, bacterial infections, viral infections, and fungal infections. So they have been studying the delivery of Cow lactoferrin obtained from milk, because it comes from mother's milk. It comes from colostrum. So what they've done is they've isolated lactoferrin, and they've been studying it with a wide variety of adult conditions successfully. So last year, the team in Italy that proved that lactoferrin was helpful for the prevention of recurring UTIs, they did an IC study. And it was a university in Italy. I think it was the University of Milan, but don't quote me on that. Anyway, what made their study particularly meaningful is that they looked at the bladder before and after treatment physically, and they measured inflammatory markers through blood testing before and after. And so they had 31 patients that they gave lactoferrin to for roughly five-ish months. At the end of that period of time, red inflamed bladders became pink and healthy. Hunner's lesions were almost completely gone, and systemic inflammation measured through blood testing had dramatically reduced and improved in patients who used lactoferrin over time. And that makes sense. It helps us understand why the Hunner's lesions would have virtually disappeared, because lactoferrin boosts your ability to fight viral infections. I'm taking it again now for this. So we have a lot of patients now who are using lactoferrin successfully. The challenge with lactoferrin is that, number one, there's a lot of lactoferrin on the market. Some of it's very cheap, $30. Some of it's very expensive, $200, $250. The lactoferrin that I decided to put in the IC Network shop comes from Australia, the same place that they source the lactoferrin for the IC study. And so it doesn't help everybody, but it's worth a shot if you happen to have Hunner's lesions, especially that do not appear to be responding to therapy. I mean, it literally comes from milk. It's not made in a lab unless you buy bioidentical lactoferrin. There are companies on the market, they're calling it human lactoferrin. It's not human lactoferrin. It's made in a lab. It's bioidentical. Look on the label. And it can be very, very expensive. So if you wanted to try the lactoferrin, it's in the IC Network shop right now, and you can get 15% off because we're doing our end of the year sale. So promo code Happy New Year. So all the supplements are on sale right now. Bladder Builder, Bladder Rest, PEA, lactoferrin, Cysto Protect. The national shortage is over. They said they're getting it from the manufacturer tomorrow or the next day. They will ship it to us. So I put Cysto Protect back in stock too. And so you can take 15% off of your Cysto Protect order if you want. Just know that with the Cysto Protect, we're not going to be able to ship it for probably 2 weeks because we don't have it yet. They don't have it yet, but it should get here. It's in the queue. Oh boy. All right, guys. Well, listen, we've been going for 2 hours. Catherine said, I had a really bad flare and ordered the lactoferrin from Italy. It really helped. So far, so good. Excellent. I'm really glad. I wanted to import the lactoferrin from Italy, but there were all these customs forms that would have cost tens of thousands of dollars to go through, and I could not afford that. So, and just know that the lactoferrin from Italy still comes from Australia. So they just mix it with other things. Diane said, I've always been put under general anesthesia when getting steroid injections into my bladder. I've had it done twice, and it's really helped a lot the second time. My urogyn wants to continue doing the steroids every 6 months, and I'm Concerned about being put under for the cause. I have another surgery to do this year. I take lactoferrin 100 milligrams, one a day, too, and I believe that it helps. I don't know if we have any long-term safety data with steroid injections into the bladder. But I can look. Hold on. Let me here. I got a quick way of looking. Let me see. I'm just going to go over to the American Urology Association website. I'm going to go to the IC guidelines. Let me search the guidelines for the word steroid. My voice is about done, guys. You can tell. Let me take a cough drop. Okay, not that study. I don't see corticosteroid-associated fatal mycobacterial sepsis occurring 3 years after installation of BCG. Okay, that's not the same thing. Yeah, I don't know, Diane. Lori said, made it through Christmas with low-grade IC issues, all manageable finally. Question about product sale. I'm in New Zealand. I have the estrogen atrophy on the weak pelvic floor. Which is best for this? Bladder builder would be my first choice for the estrogen atrophy. I would do bladder builder or bladder rest. If you flare with a probiotic like yogurt, then you can't do bladder builder. I would do bladder rest. If you have pain, I would do the PEA. And you could do both. A lot of patients do bladder rest and PEA together because they're not the same thing, apples and oranges. And we do ship to New Zealand, so go for it. And you can use the sale. Lori said, I've been taking Cystomen for the last 18 months, but I recall you recommended something more efficient this year. You love Preleaf. Yeah, bladder builder, I think, is, Cystomen is kind of like the kitchen sink approach to the bladder. They have a lot of different things in it to try to treat a lot of different potential causes. Some might be helpful, some might not be helpful. Whereas bladder builder is really targeted with the chondroitin for the bladder wall and the PEA for the pain. So I'm a bladder builder girl myself. I mean, that's the one that it has the best reviews on Amazon, has the best reviews in the IC Network shop. I think it's the best supplement on the market. Melly said, thank you. Glad you're feeling much better. Get continued rest. I appreciate you. You're very welcome, Melly. And Happy New Year, you guys. New Year at our meeting next Sunday. Knock on wood. Hope I'm better. I hope I'm better. We're going to talk about New Year's resolutions and what can we do in a new year to kind of take charge of our symptoms. If you have been flaring this year, if you're just not getting better, sorry, that's for the throat. We need to figure out why, because we want you to get better. Don't keep doing, it's very hard to accept change, I mean, listen, at some point in time, you have to go, what I'm doing is clearly not working. Maybe we need to try something else, right? So this is where you have to be willing to kind of step away from certain things that aren't working and maybe try new things. And that's what our national guidelines say. If you're not responding to treatment, if you're getting worse rather than better, let's reconsider that diagnosis and try some new things. So that's what I wish for you. In 2026, let's embrace some new things. See what we can do to get to the root cause of your symptoms and try to get you better. All right, my friends, my voice is done. My cough is coming back. So I hate to leave when I've still got almost 30 people here, but I gotta protect the throat. So if you find these meetings helpful, please come on over to the IC Network, sign up to get our free newsletter, become a member to get our magazine. We'll be writing our winter magazine next month. I would have done it this month, but I was too sick to do it. And Happy New Year. And listen, for New Year, I know you're going to be tempted to have champagne. Buy non-alcoholic champagne. It's really good and it's not going to irritate your bladder as much. All right, you guys? We made it. We made it through Christmas and a new year beckons. Let's look at this as an opportunity to make our lives better. That's what I wish for all of you. All right, guys. Bye, YouTube.